So today we're going to talk a little bit about image quality. So at the end of this lecture, you should be able to have a better understanding of the factors that affect signal to noise ratio, contrast to noise, spatial resolution and scanning time. So remember I said that with MRI, one of the most powerful things that MRI can give you is contrast resolution. So that's the ability to tell similar tissues that are adjacent to one another apart. So when we're scanning, it's a constant trade-off between how long you want to scan for, as in scan time, versus what sort of resolution you want to get in terms of spatial resolution and contrast resolution. Just remembering that probably the biggest enemy of MRI scanning is movement. So the longer you try and scan someone and tell them they have to stay really still, the more likely you are to get movement. And at the end of the day, that's the thing that's probably going to compromise your image quality more than anything else. So image quality. So there's four main considerations determining image quality. We just mentioned what they were: signal to noise ratio, contrast to noise ratio, spatial resolution and scan time. As I said, the way that scan time ties up into that is that typically the longer you try to scan someone, the more likely they are to move. So signal to noise ratio. The signal is the voltage induced in the receiver coil. So this depends on a lot of factors that can be altered by the radiographer sitting at the console. Okay? But noise is generated by the presence of the patient in the magnet themselves. So noise is something, so there's inherent noise in the system. So when we have an MRI scanner, the biggest noise object that we can introduce into the system, the biggest inhomogeneity into the system, is exactly what we want to do in terms of the patient. Okay? So if we didn't have to scan patients, we'd be right. But as soon as we put a patient inside the ball, that introduces inhomogeneities and introduces noise. There's also inherent noise in the system just in the electronic sources. Okay? But the thing is that that noise is there all the time. We can't really change parameters to get rid of a lot of that, but we can change parameters in terms of scan field of view, acquisition matrix, number of excitations, which will improve the signal to noise ratio. So that's essentially what we're going to talk about. So noise is constant for every patient, depends on the build of the patient, depends on the area under examination, and depends on the inherent noise in the system. So another source of inherent noise can really be, we spoke a little bit about Faraday cages. If the Faraday cage is not really attenuating signals from outside the room effectively, noise can leak into the room. Factors that affect signal to noise are the proton density of the area under examination, the Voxel volume. So does everyone understand the concept of a pixel and a voxel? It's something that you would have covered in year one. So a pixel is basically, if we look at our scan field of view and we look at our acquisition matrix, if we divide the scan field of view by the acquisition matrix, that will give us our pixel face. So for instance, if we've got a 256 by 256 millimetre field of view and we've got a 256 by 256 matrix, the pixels will be 1 millimetre by 1 millimetre. Okay? So then our voxel is the depth. So it's the slice thickness. It's the pixel face times the slice thickness. So again, if our slice thickness is 1 millimetre, we've now got a 1 millimetre by 1 millimetre face with 1 millimetre depth. So we've got 1 cubic millimetre voxel. So the voxel volume, the TR, the TE, the flip angle, all things that we can control as the radiographer. Again, we can control that voxel volume. The next is the number of acquisitions, or how many times we fill out K-space. So we might do it once, we might do it 8 times. And the coil type. And I would argue that the coil type is probably the most important determinant of signal to noise ratio. So in MRI, if you go into an MRI room, what you will find is that normally they'll have a cabinet full of different coils for the different parts of the body that you want to examine. So a different coil for looking at the head versus the neck versus the spine, shoulder, knee, foot, wrist, etc. So So proton density. How does it control SNR? So the number of protons determines the amplitude of the signal received. So essentially, depending on the proton density of the tissue, that will have a determination of the signal to noise ratio of the experiment. So areas with low proton density, such as air-filled lungs, have low signal and therefore low SNR. Areas with high proton density, such as areas in the pelvis or muscle, will have higher proton density and therefore higher signal and signal to noise ratio. Okay, so signal to noise ratio is just proportional to the proton density of the tissue under investigation. Okay, so if we're looking at lung parenchyma, because there's a lot of air-filled spaces, the signal to noise ratio is pretty low. Voxel volume. So the brightness of the pixel represents the strength of the MRI signal generated within that voxel. Okay, so it's dependent on how many spins are in that voxel. So the voxel represents the volume of tissue within the patient and is determined by the pixel area and the slice thickness. As I said before, if we think of that example, 256 by 256 field of view, divided by that size matrix will give us a 1 millimetre squared pixel face. And then depending on the slice thickness, that will tell us how much volume is within that voxel. Okay? So just say, for instance, we had the same field of view, 256 by 256, but this time a 128 matrix, our pixels now become 2 millimetre squared. Okay, so you can see that automatically we've gone from having 1 by 1 to 2 by 2. That's how much we've increased that volume by. Okay, so we've gone from 1 squared millimetre to 4 just by changing the acquisition matrix, halving it in both directions. So large voxels contain more spins and therefore have more nuclei, more protons, and therefore they contribute more towards signal, because we physically just got more spins within that area because we've changed the volume, the voxel volume. That's what it looks like. If you think of this, this is our field of view, this is our slice. So our voxel is just that pixel face times the volume. Okay? The voxel is altered by a change in the slice thickness, said that before, so it's really, that voxel depth is really just determined by the slice thickness. A doubling of the slice thickness doubles the voxel volume and therefore the SNR. Pixel areas are altered by changing the matrix size or the field of view. Okay, so we can either think about maintaining the same field of view and lowering the matrix to get more SNR, or we could slightly increase the scan field of view. So doubling the field of view doubles the voxel volume along both axes of the pixel and increases the voxel volume and SNR fourfold. So remember I said before, if you think of that example, 256 by 256, that's our field of view and that's our matrix, it's 1, but if we drop that matrix to 128, all our voxels now become 2 by 2, so therefore 4 times increase. We've gone from 1 squared millimetre to 4 squared millimetres for our pixel face. So scan field of view is one of the most potent factors affecting SNR. So if you scan an area and you say, look, that image looks a bit noisy, I want to increase the SNR, one thing you can do is change the field of view. So if we change the field of view, what does that affect? What else will that affect if we increase our field of view, keeping all other factors equal? Changes the spatial resolution. So if our field of view becomes larger, our pixels become larger also, and that affects our inherent spatial resolution. Just remember, some of the things that we want to look at are quite small structures. So for instance, when we look at a study of the 8th cranial nerve, we're doing scan thickness in the region of 0.3 of a millimetre. Okay, so we're really looking for very fine structures. So the flip angle controls the amount of transverse magnetisation that is created, which induces a signal in the coil. the maximum signal amplitude is created with flip angles of 90 degrees. And again, that was one of the questions that we covered in the tutorials this week. Okay, so if you want to get a maximum of signal, we want that flipping of our net magnetisation vector into the transverse plane. So the lower the flip angle, the lower the signal to noise ratio. And again, when we're talking about gradient echo imaging, sometimes we're using that excitation flip angle at something much less than 90 degrees. So you can see already with our gradient echo imaging, that's one of the determinants about why they have characteristically lower SNR than spin echo sequences. The TR, or the time to repetition, or repetition time, controls the amount of longitudinal magnetisation that is allowed to recover before the next excitation pulse is applied. So all that's saying is that once we flip our spins into the transverse plane, depending on what sort of tissue type they are, we know that they take an amount of time to realign with the magnetic field. If we don't wait long enough for them to completely realign, so say they get halfway, and then we hit them with another 90-degree pulse to start the next sequence, what will happen is we won't have full magnetisation available to flip into the 90-degree plane. Okay, so that's all that's saying, and that feeds into this idea of saturation effects, and also feeds into another one of the questions that we covered, which was about T1 relaxation time increasing with increased magnetic field strength. And the idea that if you change your protocols from if you change your magnet from a 1.5 Tesla to a 3 Tesla, and you want to just import your scanning protocols, there's a few tweaks you have to make around that TR time. Because the T1 relaxation times, the amount of time it takes to realign, increases with increased magnetic field strength. A long TR allows full recovery of the longitudinal magnetisation so that there is more spins available to be flipped on the next repetition. Okay? So all that's saying is that in an ideal situation, we would wait a long amount of time, a long TR period, before restarting our examination. Depending on the tissue type under examination, sometimes that's not entirely possible, because as you'll see later on, that TR also plays into scan time. So if all our TRs were infinitely long, say 10 seconds, versus our standard TR time for, say, doing imaging in the brain of about 4 seconds, all of our scan times automatically become 2.5 times longer. So our 3-minute scans look more like, 8 minutes. And if we were doing 5 of those in a series, I guarantee that number one, we wouldn't get as many patients scanned in a day, and number two, a higher proportion of them would be inclined to move. But in essence, what we're talking about here is a longer TR increases signal to noise ratio. And again, that echo time controls the amount of transverse magnetisation that is allowed to decay before an echo is collected. So remember, we looked at that video, I think in lecture number 3, where I showed our magnetisation being flipped into the transverse plane, and then it starts to dephase, and then we apply a 180-degree pulse, we flip them over to the other side, and then wait for the collection of that echo. So we can determine with echo time when that echo is collected. So we either acquire a short TE for T1 weighted or a long TE for T2 weighted. Okay? And the longer we wait, the less magnetisation we have in the transverse plane because it's decayed through that T2 effect. Does that make sense? And someone said to me the other day, why don't we collect all of it straight away? So the reason that we don't collect all of it straight away is we're looking for that divergence. So when we think of that decay curve, they're all at the same point in time when we create our FID. So if we acquired the FID straight away, what sort of weighting would that give us? Proton density. Okay? It'd be a proton density weighted image because we've got no evolution of T1 or T2 contrast yet. But as that decays over time, so we're going from this point, they're fanning out. At this point in time where we measure them, where they've separated, that's what allows us to impart a T1 or a T2 weighted image with what we've acquired. So we want to wait longer to separate out the different tissue types. And if you start looking at images of the brain, it become completely obvious that T2 weighted gives you really nice differentiation between grey and white matter in the brain. And they have very similar times, but the longer we wait, the more discrimination we get. So the TE controls the amount of transverse magnetisation that is allowed to decay before the echo is collected. Okay? A long TE allows considerable decay of the transverse magnetisation to occur before the echo is collected, while a short TE does not. Okay, so again, just our learning point, long TE reduces SNR. The other one that we can talk about is this idea of NEX, or number of acquisitions. So it's called different things by different manufacturers. I think NEX is GE speak. Siemens call it number of acquisitions. So different manufacturers just have different terms for the same physical process. So NEX controls the amount of data that is stored in each line of K-space. Okay? Doubling the NEX doubles the amount of data that's stored in K-space. The data contains both signal and noise, so we're collecting that inherent noise in the system plus the signal that we've generated from our MR. The reason that's important is noise is random, the signal, however, is not. So essentially what happens with NEX is that if we do 2 NEX, we don't increase the signal to noise ratio by 2, we increase it by the square root of the number of NEX. Okay, so if we increase it by 4, so 4 NEX makes the scan time 4 times longer, but it only increases the signal to noise ratio by a factor of 2. So it's kind of not the most efficient way to increase signal to noise ratio. So 4 times longer for a 2 times gain in SNR. So if you really want to increase your SNR, you might just want to look at changing the field of view slightly or the slice thickness. As I said, probably the most important determination of signal to noise ratio is the coil. So the type of coil used affects the amount of signal received and therefore the SNR. So we have different kinds of coils. Quadrature coils are ones that typically transmit and receive on the same coil. So an example of a quadrature coil is something that has to cover the whole body. So a head coil where it slides over the head versus a coil that you lie on. So a spine coil where you're just lying on the coil is more a surface coil. There's new development with surface coils now where we start to use array coils. So I think you probably covered this idea of arrays in ultrasound physics. So rather than having one large coil to detect, those coils are divided into separate smaller elements, array coils, and the addition of signal from all those individual array elements is actually stronger than having a single loop receiver. So now there's a lot of development going on in array coils to the point where we're now seeing 128 channel array coils. Okay? So that's a new development that's been going on in MRI over time. But in general, the size of this receiver coil should be chosen such that the volume of interest, the volume of tissue imaged optimally fills the sensitive volume of the coil. So what that is saying is you really don't want to try and image a wrist in a head coil. Okay? You want the coil that you're using to fit the piece of anatomy under examination. Contrast to noise ratio is defined as the difference between the signal to noise ratio between the different areas, and it's controlled by the same factors that affect SNR. And as I said before, this contrast to noise is probably one of the things that is important in MR. It affects our ability to visualise differences between areas. So it determines the eye's ability to distinguish areas of high and low signal. Okay, so it's essentially anyone that wants to look at images and do image interpretation is always trying to maximise the difference between tissues of very similar characteristics that are adjacent to one another. And a good example is just thinking about grey and white matter in the brain. The purpose of administering contrast agents is to increase the contrast to noise ratio between pathology and normal anatomy. Does anyone know what sort of contrast agents we use in MRI? So they're gadolinium-based contrast agents. Do you know what they do? So they bring about pronounced T1 shortening of the tissue that takes them up. So characteristically, what does cancer need to do to grow from a normal tissue to become a cancer? It needs to recruit a blood supply. So for it to grow faster than surrounding normal tissue, it needs to have its own blood supply. So when we inject contrast media into someone's vein and then we image, essentially what we're imaging is the increased contrast uptake to a tumour. So because gadolinium brings about pronounced T1 shortening, we do T1 weighted scans post-contrast, and that makes anything that takes up contrast appear bright. Spatial resolution is controlled by the voxel size. Small voxels result in good spatial resolution as small structures can be more easily differentiated. So spatial resolution is controlled by both that pixel face and the voxel size. In large voxels, individual signal intensities are averaged together and not appreciated as distinct within the voxel. So what all that is saying is that if we're trying to image a structure that is 3 millimetres in size and our voxel size is, say, 5 millimetres, we're not going to necessarily be able to differentiate that from an adjacent normal structure. So when we're looking for really fine structures, we need to have a fine matrix. We need to have a small field of view, a small matrix, small pixel sizes, and ideally small slice thickness. The voxel size is affected by the slice thickness, the scan field of view, and the number of pixels, or the matrix size. Spatial resolution and slice thickness. So the thinner the slice, the greater the ability to resolve small structures in the slice select plane. So remember I was saying when we image the 8th cranial nerve, looking for things like acoustic neuromas or cholesteatomas, they're very small structures. Our slice thickness can be as small as 0.3 of a millimetre, because that's the size of the cranial nerve that we're looking at. So a thick slice decreases spatial resolution. Spatial resolution in the field of view, the size of the field of view also determines the pixel dimensions. So remember I mentioned before about the 256 by 256 field of view. With the 256 by 256 matrix will give us 1 millimetre square pixels. If we increase that field of view, say from 256 to 512, and keep the same matrix, our pixels again will become 2 millimetres squared. So the size of the field of view also determines the pixel dimensions. A large field of view results in large pixels. Increasing the field of view therefore decreases the spatial resolution. So that's the trade-off that we're working on all the time. If we change our field of view to increase our signal to noise, to improve it, it also can have a negative impact on spatial resolution. Spatial resolution matrix size. The matrix determines the number of pixels in the scan field of view. So small pixels increase spatial resolution as they increase the ability to distinguish between two structures close to one another. Increasing the matrix size, so you can see here the example where they've spoken about 128 by 128 to 256 to 256 increases the spatial resolution, so our pixels become smaller. But again, when our pixels become smaller, we also have an impact on contrast, on signal to noise ratio. So that, again, that's the trade-off. So scan times are important in maintaining image quality. Long scan times give the patient more chance to move. So when we talk about movement, we're not just talking about things like patients moving their head within the scanner if we're doing the brain scan. Movement is also physiologic. So say we're doing chest imaging, it's also that inherent breathing with the chest wall moving. So again, we just have to have strategies, acquisition strategies to manage that movement. Some of those are breath hold. Okay, so we need to be able to make our scans run fast enough so that we can do the imaging in a breath hold, a single breath hold. Factors that affect scan time is our repetition time or time to repetition, the number of phase encodings, so that phase encodings is related to the matrix, and the number of acquisitions. But essentially, we can work out scan time by just this very simple equation, TR times the number of phase encodes times the number of negs. So repetition time, doubling the TR doubles the scan time. Number of phase encodes, this determines the number of K-space, number of lines of K-space that are filled to complete the scan. If the number of phase encodings are doubled, the scan time also doubles. So that number of phase encodings is related to our matrix. Number of excitations doubles the scan time. Okay, so that just showing you how those three parameters, as you can see in that equation, affect our scan time. Trade-offs. It's probably now obvious that there are many trade-offs when selecting parameters within a pulse sequence. Ideally, an image has a high signal-to-noise ratio, good spatial resolution, and is acquired in a very short scan time. However, this is rarely achievable, as increasing one factor inevitably reduces one or both of the other two. So as I said, when you're the radiographer sitting there running these scans, that's the sort of juggling that you're doing when you're sitting there thinking, okay, this is not looking the way I think it should look. How am I going to improve the image quality, or how am I going to get more spatial resolution? That's the trade-off that's going on in your mind when you're trying to improve the image quality. Okay, and again, just a table there to kind of give you an idea of how all these factors affect. You know, if we change our negs, we change our scan time. We change our matrix, we can change our scan time and our resolution, etc. And just talking about image optimization, if we want to optimize spatial resolution, these are some of the parameters that we may want to trade off, and that's the consequence. So if we trade one, if we try to change spatial resolution, we need to remember that that will also have an effect on SNR. Okay? So any questions about that first part of the lecture? Clear as mud? All right. Let's talk a little bit about artefacts. So, like kind of in all sorts of imaging, sometimes our imaging can be degraded by artefacts. I would argue that artefacts sometimes do degrade images, but sometimes they're also very good at highlighting pathology. So we'll just talk about them as we go through. So we're going to talk about the main artefacts in MRI, and we're going to discuss how to reduce some of them. So an artefact is an unwanted pattern or structure that does not represent the actual anatomy. Image artefacts can be misleading and interfere with diagnosis. So it's kind of important to understand how some of these artefacts are made, because quite often when you're imaging, you might have a radiologist come to you and say, so for instance, a really good one is when you are scanning in the abdo, and at the first slice on your run in the aorta, you'll see a signal, depending on how you've set up your scan. And can't tell you how many times radiologists has come and said, you didn't scan enough volume, there's pathology. And you go, no, that's not pathology, that's inflow artefact. So what that is when we set off our 90-degree pulse, and then we want to generate an echo, we fire in a 180-degree pulse. there's a short time delay between those. That time delay, do you remember, is that parameter we spoke about the other day, tau? So what happens is when you excite this slice with a 90-degree pulse and then send it in a 180, blood that you excited in the aorta has moved on. It's flowed out of the volume. So when you collect that slice with your 180 degree, there's a different set of blood in that aorta. The rest of the anatomy stayed in the same spot, but blood flowed. So that will give you an inflow artifact. And if you as the radiographer are aware of that, when someone comes and says to you, you didn't scan high enough, you go, actually I did, that's an artifact. You just didn't recognise it as that. So that's just an example of understanding what it, like if you know the principles behind acquiring the images, you'll know what that means. So image artifacts can be misleading and interfere with diagnosis. The complexity of magnetic resonance imaging unfortunately has brought with it many new and confusing imaging artifacts. Luckily, many of these can be interpreted easily and do not interfere with diagnosis. So that's just an example, that inflow artifact that I told you about. There are many sources of artifacts. Some of these can be imaging processing. So you may have, when you collect all your data, you send it away to your array processor and it does something funky with it and gives you an artifact. There can be patient-related artifacts. So these might be examples of people that have metal inside them. So they might have dental braces, dental fillings. They may have had a cholecystectomy where they've got small clips on their cystic duct from where their gallbladder was removed. So these might be patient-related artifacts. We can have radio frequency-related artifacts. So an example for that might be that our Faraday cage is not doing its job and we're getting leakage of RF into the room. And again, that's not necessarily something that we can fix as radiographers, but it may mean that we need to have a service call. Probably the other one that you see a lot is the lights. So the lights that go in MR rooms, you tend to not want them to be incandescent light globes because when they blow while you're scanning, you get a big artifact. They'll put a zipper artifact right through the middle of the image. So they tend to use other sorts of lighting, if you can, more DC than AC related. So more sort of lower voltage DC lighting rather than 240 AC. External magnetic field artifacts. So one of the things that we think about when we put an MR scanners in is sighting. So we really want to put our MR scanner in a facility, in a hospital, in a private practice, away from moving metal. So we think about things like elevator shafts and access to car parks so that we don't have that influence of metal moving in the fringe field. Magnetic susceptibility artifacts, so these are the ones that are inherent in us in terms of airfield structures next to soft tissue or bone, so lungs, sinuses, etc. Gradient artifacts, so these are ones that can be induced by the gradients inherent in the system, errors in the data, flow-related artifacts. So that flow-related artifact was the one I told you about before with the inflow artifact, where we've excited blood, it's slightly flowed out of the slice. Then when we collect it, we're not collecting the same blood that was there when we excited it. These are some of the more common ones will now be discussed. So chemical shift. So the principle behind chemical shift artifact is that the protons from different molecules precess at slightly different frequencies. So remember I said that when we do clinical MRI scanning, like scanning on humans, essentially what we're making is maps, geography maps of fat and water, because that's mostly what is in us in terms of protons. So at 1.5 Tesla, there's a slight precessional frequency difference between fat and water, and it's 220 Hertz at 1.5 Tesla, or double that at 3 Tesla. So remember, when we put all our image data into K-space, what we do with that image data is we apply a Fourier transform to all those different frequencies, and that transfers that into spatial information. So it's easy for the system to, it doesn't distinguish between fat and water. So when it sees a signal intensity, it just assigns it as being that particular frequency in that particular pixel or voxel. So what it can do is it can sometimes give you an artifact based on this frequency difference between fat and water. So the protons in water precess slightly faster than those in fat. Chemical shifts artifacts are seen anywhere where there's fatty structures and water, where they sit up against water structures. So good examples are the retroorbital fat when we're doing brain imaging. Sometimes we can see it along vertebral end plates, or we see it in the abdomen at organ fat interfaces. And again, so that's what it looks like. So all this is 2 cylinders of fat and water, and this is what happens, is that image, that border should be sitting wholly within that cylinder. But because of that phase shift, it gets slightly moved. And here's an example of where you see it. So here's a cross-section through our abdo. That's our vertebral body. That's our spinal cord. This is our kidney on one side and kidney on the other side. And this is sort of intra-abdominal fat. And you can see that we've got this dark line around one edge of the kidney, and on the other side we see it as being a bright line. And that's just because that fat and water has been shifted. Okay, so that's what it looks like. The MRI scanner uses the frequency of the signal to indicate its spatial resolution. Remember I said before, when we take all that data in K-space and Fourier transform it, all we're doing is changing those frequencies into spatial information. So all it does is it just mismaps those frequencies in the spatial direction. So since the water in organs and muscle resonate at a slightly different frequency than fat, the MRI scanner makes the frequency difference as a spatial position difference. So it just erroneously maps it in the wrong location. And again, it's just one of those things where when you're doing scanning, you know that this is a possibility, you make adjustments to minimise the effect, or if you see it, you just recognise that it's an artefact and don't let it worry you. As a result, fat-containing structures are shifted in the frequency direction from their true positions. Okay? And again, I would argue that we actually use this technique for some diagnostic purposes. So it's really good when you're looking at adrenals. There's a particular tumour that you can get called a pheochromocytoma. So you can use that information to tell you a little bit about the pathology, that pheochromocytoma. So one man's artefact is one person's pathology. So again, if we consider what chemical shift is, all we're doing is we've got our gradient, all we're doing is shifting that artefact, that frequency just gets shifted in spatial position. And it can just result in that overlap of signals, which is what we saw there. We've got overlap here where it shouldn't be overlapping, and over here we've got a difference in the signal. And again, just showing what it looks like around there. Okay? There are ways to diminish the visibility. Not sure if that, yep, so here it is here. So one of the ways we can do it is we can do fat suppression techniques. So because that fat and water has a slightly different precessional frequency, 220 hertz at 1.5 Tesla or 440 at 3 Tesla, we can actually use that also when we're doing MRI imaging to suppress the signal from fat. Okay, so it can be that we use a fat suppression technique. So what that does is when we when we make our image, as part of the acquisition, we suppress all the signal from fat. And that's really good for looking at things like bone bruising. So people that have a knee injury and may have, say, an ACL tear. When you have an ACL tear, an anterior cruciate ligament tear, you normally get 3 things that are associated with it. You'll get an ACL tear, you'll get a tear in the meniscus, and you'll get a bone bruise. And that bone bruise we think represents a microfracture. So like all things, when you get a microfracture, you get increased water. So if we suppress the signal from fat when we're doing bone imaging, really good for looking at edema. So we can see a small bone bruise. So that's kind of how we use our fat suppress technique. We also use it a lot when we're doing breast imaging because we're interested in the breast parenchyma and not the surrounding signal from fat. The other remedy is to increase the pixel size by keeping the field of view the same and decreasing the necks. We can use a lower magnetic field strength so that that frequency difference is not so large and therefore they won't get mapped across. We can use a long TE because that will change the amount of dephasing that goes on. In all reality, chemical shift imaging is not something that plays, doesn't come into your reckoning a lot when you're doing imaging because lots of times you actually want to, you recognise what that artefact is, it's not an issue when you're reporting it, and lots of times you actually use it to help in the diagnosis. Aliasing. So aliasing occurs when the field of view is smaller than the body part being imaged. When hydrogen nuclei outside the area of interest are excited, the signal may return, they return as interpreted as having originated from within the imaging field of view. It's then projected over the real portion of the image on the opposite side of its actual location. And it's quite often known as wraparound artefact. So that's how it looks. So while we're here just looking at this image, this is a T2 weighted sagittal image of the brain. Remember I was saying to you before that just thinking about that decay of signal, if we look at our FID, we're just looking at proton density. The longer we wait, the more differentiate we can look at tissues. So here's a really nice example where in the brain, sagittal T2 weighted, all the bright areas are CSF, darker areas are brain parenchyma. We can see the difference between surface grey matter and deep white matter. So here's our grey matter and here's our white matter. So just while we're here, you can see what I'm talking about in terms of using that evolution of contrast mechanisms to pull apart different tissue types. It's also a really nice example of wraparound artefact. So what we see here is here's our sagittal brain. We can see that we've just made our scan field of view smaller than the anatomy. So what we're seeing is wraparound artefact. So we've seen some tissue, so this is the back of the brain here, that's now been wrapped to the front. And here's the front of the brain. You can actually, if you look at that, that's the nose in there. It's now been put at the back of the brain. So that's wraparound artefact. So really to make wraparound artefact like this, you need to intentionally go and create this because you wouldn't really scan that with that field of view. And if you did, there's another function that you can turn on as the radiographer sitting at the console called no phase wrap, which just extends the frequency so that they don't get miswrapped. So there's a really useful tool for limiting this. It can be corrected. So a couple of ways that you can correct this artefact would be to use a larger scan field of view or to increase using your no phase wrap, which just extends what artificially extends the scan field of view, even though you don't look at those images. You can always, when you see this phase wrap, if you haven't recognised it and you think that it might be pathology, a way to sort of distinguish between the two would just be to repeat the scan with a larger field of view and see if it's still present. So if you increase the field of view here, you would expect to see this wrapped area either not appear in the image or move further forward, depending on how large you've increased it. Partial volume averaging. So this is where particular structures of interest are contained within two contiguous slices. Do you know what contiguous is? So next to one another. So you've got one slice, you've got no gap and another slice directly next to it. Okay, so that's contiguous, as opposed to having a slice, a small gap, and then another slice. So lots of times you might scan through the brain with 4 millimetre thick slices with a 1 millimetre gap between. Okay, so if you've got that gap, they're not contiguous. Contiguous means they're directly next to one another. It's worse with thick slices and large voxels. So the remedy is to use thinner slices, and just remember that thinner slices is going to change your signal to noise ratio. So you might need to make something that increases the SNR if you've made your slice thinner. The other thing is that if you're trying to cover a particular piece of anatomy and you make your slices thinner, you're suddenly going to need more to cover the same area. And that's just an example looking down here. So again, this is an axial image of the in the skull. We're just looking at seeing some cranial nerves coming through here. So on a thick slice, we can kind of see this, you know, a small little difference here in this CSF area. But when we look at our thinner slice, we can start to see that that's a cranial nerve coming through that area, just because we've used thinner slices to carve up that area that more appropriately fit the size of the structure under investigation. Magnetic susceptibility artefact. So this occurs as a result of microscopic gradient changes. So what that's really saying is that when we have metal within the body, when we do our imaging, we can have a small magnetic field, much smaller than the scanner field of view, but we can have a much smaller magnetic field associated with that piece of metal, okay? Or variations in the magnetic field strength that occur near the interfaces of substance of different magnetic susceptibility. So they don't always have to be metal. It can be, as I said before, we can get susceptibility changes from things like air, but the other one we get it in is in blood. So has anyone heard of a technique called functional MRI? So functional MRI is where we put someone in the scanner, we run a very particular imaging sequence and we get them to do a task. That task might be a finger tap. So if we get them to do a finger tapping exercise, we can actually map out what part of the brain is making the fingers move. So this is functional MRI. It's a task, and then we look at what part of the brain makes that task occur. The reason we can do that with MRI is hemoglobin has a different magnetic probability depending on whether it's carrying oxygen or not. So when blood flows to the brain and it undertakes a task, it strips that oxygen off as part of its energy source. And when the blood gets the oxygen removed, it has a different magnetic profile. So we can map that out. That's a susceptibility change. So that's just an example of another sort of case where saying that it doesn't have to actually be metal, as in, you know, screws or pins from an orthopaedic operation. It can be changes in iron in hemoglobin. So they're commonly seen around ferromagnetic objects inside the body, and these might be things, as I said, like dental work, fillings, braces, might be around surgical clips, like if you've had a cholecystectomy, had your gallbladder removed, they put a couple of clips on the cystic duct because it's no longer there. Main causes of metal and the iron are metal and iron content in hemorrhage. So with MRI, if we're doing imaging of the brain and we've seen someone that's had a hemorrhage, we can actually age that hemorrhage, because as that blood gets reabsorbed by the body, it leaves behind what we call hemosiderin, which is a particular kind of iron that's associated with blood. So when you see someone that's got a hemorrhage, you can tell approximately how many days old it is. So here's an example of just some of those susceptibility artefacts. So the gradients cause dephasing of spins and frequency shifts in the surrounding tissues, and this can cause signal loss. The net result are bright and dark areas with spatial distortion of surrounding anatomy, and it's worse with long echo times and worse with gradient echo sequences because we don't have that 180-degree pulse to help recover those T2 star effects. So here we just see an example. Here's a sagittal brain, and you can see that all this sort of facial structure has been distorted, and you can see this very bright area here next to this adjacent dark area. So that would be pretty classic for what we would see with trying to do a brain scan on someone with dental braces. And again, here's our coronal pelvis. So here's our femoral head. Here we're seeing our greater and lesser trocanas and femoral neck, and on the other side is our iliac wing, and we've got a hip prosthesis. Okay, so we can still scan these sorts of patients. It's just that if this is the area of interest, if we're trying to look at something related to that hip joint on that side, we're not going to see it because we're going to have too much artefact. Okay, so as in anything, there are some remedies. Simple ones are just make sure the patients don't have any metal when they go in the room. There's a few things that we want to ask about: aneurysm clips and metal implants. So some of those are not MR compatible, so we don't scan patients with those. Sometimes we might see artefacts, metal artefacts, and we just want to have an explanation as to what they might be. I've scanned plenty of people that you say, look, I've done an E-scan on you, you've got a little bit of metal in there, do you know what that is? And they'll go, oh, I do remember getting shot with a pellet gun when I was 6 years old, and maybe it's still there. And that's what it is. It's still there. Most implants can be scanned, but some of them will cause local heating, so you probably covered that in some of your safety stuff. When imaging in the vicinity of a metallic artefact, it may obscure the anatomy under examination. That's exactly what we see there. It's obscuring that anatomy. We can use particular sequences like spin echo sequences to try and reduce the artefact. And just remember that sometimes that artefact is also, useful to us. As I said, seeing that artefact with a bleed in the brain can just help us to know how many days ago that bleed occurred. Zipper artefact appears as a dense line on the image at a specific point. It can be controlled easily. So zipper artefacts to me are mostly come from errors in the system. So either you've got an issue with your Faraday cage, or while you've been scanning, you've had an event which has caused that artefact. And the one that you kind of see more often than not is when a light globe will blow while you're scanning. So it just changes, it just sends a small current through the room, which gets detected by the system and appears as a zipper artefact. Main thing to kind of worry about these is really that if you see recurrent zipper artefacts at your site, it means you need to get a site engineer to come in and have a look at it. So that's characteristically what we see. We see all these zipper artefacts occurring through the image. So this one here might have been where the scan room door was kept open or not completely closed, so that means that the Faraday cage hasn't sealed and you've got leakage of signal from outside the room. The other thing that occurs is when you're doing general anaesthetics, if they bring down their equipment and their equipment's not shielded. So like in all things in medicine, general anaesthetic equipment to go into operating room might cost $10,000, MR compatible costs $100,000, just out of zero. Maybe not entirely correct, but that's what it looks like. So a lot of people will try and bring equipment down to you that's not MR compatible. You get artefacts like this. Yeah, call the engineer to locate and repair it. That's basically saying you've got a leak in your Faraday cage. Cross-excitation artefact refers to loss of signal within a slice due to pre-excitation from the RF pulse to the adjacent slice. So what that is saying is that if you're doing contiguous slices, sometimes you can have some excitation which spills over into the other slice. So the frequency profile of the RF pulse is imperfect. So we kind of think that when we turn on a slice it has a rectangular shape, but it doesn't, because the inverse Fourier to get that shape is what we call a sync pulse. That's what a sync pulse looks like. So when we do slices that are next to one another, we have a little overlap here in the tails of the sync pulse. So that can mean that we do get a little bit of crosstalk. It's not really a big deal when you do clinical imaging. If you think it's going to be a big deal, you just do little slice inner gaps. So during slice excitation, there is some degree of excitation of the adjacent slices. Okay? If the adjacent slice is imaged during the same TR or soon after, you can get partial saturation effects. That's what I'm talking about in terms of it doesn't. A sync pulse will give us this, a nice square shape. but we don't have enough time to play out these sync pulses. They tend to look more like this shape, and that's what our slice profile looks like. So this is what our actual slice profiles look like, with us having a little bit of crosstalk at these slices. So that's why you'll quite often see that when people do imaging, they'll have a small gap between slices. And there's an example where we've set up a plan for axial imaging in the lumbar spine, and we've angled our slices to go through the discs. So where these overlap at the back here, we just get this little band here of crosstalk. Okay, so if you're going to do imaging like this, you can have that overlap. You just want to make sure that it's not in the area of interest. Normally the area of interest is this spinal canal here. Okay, so the remedy is leaving a little bit of gap between the slices, or you can do it in 2 runs, 2 volumes. So cross excitation, an RF pulse is not exactly square. That's what I was showing you before. Looks more like this. It's not exactly square. The width of the pulse should be half its amplitude, but it normally varies up to about 10%. As a result, nuclei in adjacent slices may become excited. So we have a little bit of overlap of magnetisation from the excitation pulse. So this energy pushes the net magnetisation vector partially into the transverse plane, and then when we excite that slice, the one next to it, there's a little bit of residual magnetisation that's been left there, and therefore a bit of partial saturation. Okay, so the same effect is produced by energy dissipation in the adjacent slices. So essentially what we want to do is really, we just want to have that little bit of slice gap in between. This number here, this 30%, I think that's a little bit too high. In all reality, you can get away with 10% space in between adjacent slices. So if you're doing a 5mm slice, you could potentially leave a 0.5mm gap to get away with that crosstalk. But as I said, it's really not something that becomes a big issue in clinical imaging. So any questions?